Good evening, everyone. Thank you for joining us tonight. Welcome to the Evexia Webinar Series. Our topic for tonight's special webinar is Auria, meeting a care gap in breast cancer screening through biological testing. My name is Joanne Iverson. I am the Director of Client Relations for Evexia Diagnostics and will be your host for this evening. Today, I have the distinct pleasure of being joined by an exciting guest, Dr. Anna Daly, who will be our presenter for this webinar. Dr. Anna Daly has spent her industry career focused on exploring the potential of our proteome to advance preventative care, increase equitable access, and empower and educate individuals to be proactive in their health and wellness. Anna currently serves as the Chief Scientific Officer for Namida Lab and is the inventor of Auria, the award-winning first at-home biological breast cancer screening test powered by tears. She is a recognized leader in tear-based research and has worked in the breast cancer ecosystem for more than a decade. She has multiple patents, authored peer-reviewed publications, and has provided both national and international presentations of her groundbreaking work. Dr. Daly completed her PhD in cell and molecular biology, as well as her postdoctoral training in biochemistry at the University of Arkansas. She has a deep love for protein biochemistry and has found her calling in the characterization of proteins through biophysical and analytical techniques. She has a knack for making complex scientific concepts relatable to the layperson, and it is one of her greatest joys. Anna is a native Arkansas and currently resides in Fayetteville with her husband and son. As always, joining Dr. Daly will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Evexia. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your question in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. In addition, you have the ability to download the slides to follow along with Dr. Daly's presentation by clicking the download button in the handouts section of the webinar interface. Without further delay, I will now turn the webinar over to Dr. Daly.
Well, thank you so much, Joanne, for that introduction. I'm very excited to be here this evening to speak with everyone. And I know it's an evening, we're all having our activities going on. So I will give you all the information you need, hopefully abbreviated and not too terribly long, but I'm really excited to also get to your questions. So first of all, as Joanne said, I'm Anna Daly, Chief Scientific Officer for Namida Lab, and we are located in Fayetteville, Arkansas. I started this project straight out of doing a postdoc in 2011. And at that time, when we were talking about breast cancer diagnosis, we were really talking about women in their late 50s, early 60s, and that was our biggest target. But as I've been working on this project for the last 12 years, most of the conversations that I have, the majority of the time, look more like the young women that you're seeing on this slide right now. We're dramatically seeing breast cancer shift into younger women, and we don't really have a good answer why on that. There's a lot of theories. Is it the rise in obesity? Is it our environment? Is it the things that we're putting on and in our skin? We're seeing it in colon cancer and lung cancer. And the biggest challenge here is our screening modalities, specific for breast cancer, aren't really great for women under 40. And so, I think as I started this journey and where it's brought me to now, we really have a need for a modality that could be applicable to women ages, maybe even down into the 20s, but ages 30 and over that can start a really important conversation around breast health. So this evening, what I'm going to present to you is Auria, our biological breast cancer screening test. We're going to talk through pretty quickly on the development work that brought us to this point, what the test is, and what the process is, and then answer any questions that you might have. So just real quick, Auria is a biological breast cancer screening test powered by proteins from tears. So it's a little bit different than other diagnostic tests. The kit comes in the box that you'll see here, comes to the patient's home with everything they need to collect and ship their sample back to us. So our lab, as I said, is located in Fayetteville. We are a CLIA certified high complexity lab, and Auria is an LDT. We are currently the only lab offering this test. So all of the samples will come to our lab. Our technology is built on, as I said, over a decade of clinical research, multiple peer-reviewed publications. We have 2 patents on this work in the US and 23 international patents. A little bit different for Auria is our clinical data supports ages 30 and over. So we do have the ability to offer Auria to women under the standard screening age. So let's get into a little bit about tears and why we would even want to build a test around tears. So obviously blood is a very well characterized diagnostic fluid, and it's the one we're most familiar with. But blood also has what's called a very large dynamic range. So it has everything from huge cells down to tiny metabolites. And while all of these things are interesting and important, it can be difficult to get down to those low molecular weight metabolites or proteins of interest within a clinical lab. And with tears, it just provides a really easy way to get to low molecular weight proteins quicker and easier and in high concentrations. Because what's happening is those microcapillaries on the inner surface of the lower eyelid are doing all the collection and filtration process for us. So the proteins are actually moving back and forth, they're diffusing back and forth across those microcapillaries, and that's just simply where we're able to catch them. Tears have been studied as a diagnostic fluid or by groups around the globe for decades, looking at everything from metabolites, microRNA, RNA, exosomes. I mean, it's just full of really interesting things, and shown to the composition of those has been shown to change in response to systemic disease. And with blood, those collection and purification processes I talked about can, in some cases, they can be a little bit expensive, and they can be a little bit more time consuming, and they can damage, and in some cases even remove those low molecular weight proteins. There are definitely ways to get to those proteins in blood, but tears just provide a really nice way to do it simple and easy and at home, where a blood collection process may not be able to do that for these specific proteins. So let's talk about a little bit about the journey that took us from discovery to validation to actual lab test. So we have publications, and those are available on our website. So I'm just going to talk through high level what we did. So when we're looking at biomarker discovery, we chose to do proteome-wide trypsin digestion by LC-MS. So basically what we did is we took tear samples from women who we knew had breast cancer and women who we knew did not have breast cancer, and those were determined by mammographic findings as well as biopsy as well as diagnostic MRIs. We broke those into groups. We digested individual patient samples, ran those on the LC-MS, and then with LC-MS, what you're doing is you're using enzymes to just cut up all of the proteins in the sample, and then you map those out and you're looking at specific fragments, and it's telling you how many fragments of that particular protein it might be seeing and what's the percent likelihood that you're actually seeing the full protein in the tear sample. Once we knew kind of what proteins we were looking at, we ranked them by statistical significance. So how big of a fold change did we see between the breast cancer sample set and the control sample set? Once we had our fold changes and we knew which ones were most statistically significant, we looked at biological significance to make sure that these had even been studied, not just in oncology, but maybe looked in breast cancer specifically, keeping our mind open that there may be some things that we were seeing, but given the extensive amount of work that's been done into proteomics and genomics, we were pretty much depending on what was in the literature to tell us what might be important to look at. So that's what the first paper covers, is it talks about we ended up with 5 proteins that we were interested in by ELISA. And what I show on this screen is basically the breakdown. So we did 51 normal, 51 breast cancer by LC-MS. We had 4 of the 5 major breast cancer subtypes. We did not have inflammatory in our data set and have not been able to collect any of those. It's just a much more rare and aggressive disease. And so we do have all the other 4 molecular subtypes. So then we took the top proteins that we were interested in and analyzed those by a simple sandwich ELISA assay in the lab. In that data set, we did 96 normal and 75 control. And then we did statistical analysis looking at RNA-novas to see where we're having statistically significant differences that even look like we were seeing a big difference between breast cancer and controls. And by that data we did, it looked really promising. We found 3 proteins that we were interested in looking at moving forward. So the 3 that we moved forward with to the next paper were S100A8, A9, and galectin-3. All of these proteins had been studied in tissue in breast cancer, and were known to be with A8 and A9, were known to be part of the early inflammatory process where it's recruiting leukocytes to the tissue to really start kind of getting everything ready for tumor formation. So in the second publication, we did a larger ELISA study. And so we were looking at our goal for this one was, can we develop an algorithm or a model whereby we could take unknown samples and classify it using the model? For that analysis, we did a training set and a test set. We had 223 normals, 81. So we were also trying to differentiate where this model might fit best within breast cancer continuum of care, because there's a lot of different places it could go. And so the callback line were women who had an abnormal finding by mammography and were called back for diagnostic imaging, but did not go on to biopsy and were not called back for further imaging. And then we also looked at 87 breast cancer samples. So we took that data set and we were able to, and in addition to the proteomic information that we collected for every sample, we also had extensive clinical information. So important to the proteins we're looking at, we were asking, did this person have an inflammatory condition that we needed to note? Were they on anti-inflammatories or autoimmune suppressant medications? We got information on their reproductive health, their breast health, family history, just normally the extensive information you would get when you're designing a clinical study. We took all of that information for our clinical validation and for the statistical analysis to see what covariates were interesting and might move forward for a model. It came back with 3 different possible models with varying AUCs, sensitivities, and specificities. And so then we selected one to move forward with a test set. And we knew that when we're talking about breast cancer screening, we wanted to make sure that our sensitivity was as high as possible, and we're willing to sacrifice specificity in order to get our sensitivity high. In order to do that, the best curve that enabled us to get the sensitivity as high as possible was this model B, which is our normal plus callback versus breast cancer. So that's the one we moved forward with. And then we did a test set. So we took an additional amount of samples and ran that on the model to see if that was effective and could consistently give us information on the diagnosing and differentiating between control and breast cancer. And when we looked at benigns, we were interested to see could we differentiate between benign and control, or benign and breast cancer. That's talking more on the diagnostic front. What we found was it's about 50-50. So we really focused on a model that can move in front of the continuum of care and be a launching point. So these are we have these 2 publications are available. Our 3rd publication, which is currently under review, is covering the actual clinical validation and development of the lab developed test. And we wanted to walk through that as specifically as we could, because as far as we know, we're the only ones who've developed something in a CLIA lab for tiers, and we wanted to give that data out to the scientific community on how we did it, because not a lot of people have done it. So that one hopefully will be coming soon. So now, what does Auria tell you? So we get scores from our samples. So you get a score as well as a classification. So we have that model, that diagnostic algorithm that looks at an A8 and A9 were the proteins that ended up being the ones that were truly significant, together with age. And so that's what the model looks at. And then we produce an Auria score. And we'll talk a little bit more about this further, but we have a consultation, and during that conversation, we talk about reasonable next steps depending on where you're falling within this scale. So the scale was built looking at all of the clinical data that we have collected, all of the clinical samples, and we did a retrospective analysis of that data set and saw when women came back with a finding from the time they had collected a tear sample. And that's how we built kind of the recommendations. And so really what we talk about is we're looking at, because we do see these proteins, as I said, upregulated in benign masses as well, we talk about what, we're not diagnosing breast cancer specifically, we're diagnosing an area of concern, an abnormality, and inflammation within breast tissue that needs further evaluation. So our goal is that the Auria biological results for our customers, together with a conversation with a healthcare provider, can truly provide patient activation around breast health, and that is what we have seen. So this is the sort of the generic process for the kit. So as I said, the kit's ordered, it's sent to the customer's home. They then activate the kit and they fill out a health profile. And we have a it's easy to fill out, but it is a little bit extensive because we get a lot of the same information you would get when calculating a Tire-Cusick score. We don't calculate those and give those back to our customers, but we do have that information because it gives us a lot of data when we have those conversations. So the collection process. We use what's called a Schirmer strip, and I may have mentioned this already, but we use a Schirmer strip. It's what they used to use to test for dry eye. So you place the strip inside your lower eyelid, close your eyes for 5 minutes, and during that time, the proteins will stick to the strip. After the 5 minutes, the strip is removed. It's placed inside a tube, which comes with the kit, and then buffer is added, and then it's shipped back to our lab here in Fayetteville. During the shipment process, the proteins will come off the strip and into the buffer, and that protein-containing buffer is what we run the ELISA analysis on. So as I've mentioned, you get a score and a classification. So our turnaround time is we give ourselves 10 days. Typically, it's about 4, so results will be made available, and then they can schedule a consultation with a healthcare provider. So specific to Auria, we have breast health consultants. So these are APNs and RNs who have served as nurse navigators and have lived experience talking to women about breast cancer and breast health. So they have guided everything from a screening mammogram all the way to I'm calling to tell you that you have breast cancer and I'm going to get you back in and help you with your guidance. And it is amazing the tips and tricks. I'm still learning things from, and I say they're all ladies right now, but I'm still learning things on guidance and what we can help our customers as they navigate breast health. We talk about their Auria results, of course, and their classifications. We talk about modifiable risk factors and things in their health history that we see, alcohol consumption, exercise, supplement intake. Are they different dietary changes they can make that are easy? We try to keep things easily digestible, something they can easily grab onto. We have lots of conversations. Almost all of these ladies have done risk assessments for patients in the past, so they are very well versed on explaining the difference between Auria and genetic testing, the importance of genetic testing, what a risk assessment is in breast health. We talk through all the different screening modalities. If there's confusion about a screening mammogram versus a diagnostic mammogram, what an MRI looks at and why that's important. We talk about dense breast and what that means and what an additional modality might be that might be helpful. We talk about insurance coverage, and we talk about how to talk to your provider about what your next step needs to be and how to talk about Auria. So just sort of generic to Auria and the customer journey, this is something that we offer, and it comes with every kit that we ship. They have access to scheduling this conversation with a breast health specialist. We like to talk about Auria and proteomics being part of the full picture of breast health. So we're familiar with genomics, which is obviously very important and should continue to be studied. We're familiar with imaging, and what we feel is, and what we've seen is that proteomics gives additional information and can be an activating tool for both the genomic side as well as the imaging side for breast health. It also provides with Auria, as I mentioned, just another way to educate and support primary care providers and breast health specialists and radiologists who are all having to focus on their own things. And as we know in this age of digital marketing, that we have to be hit with the same piece of information multiple times. And so what we like to talk about is that we are another point of providing the same piece of information you're already talking about, but maybe hearing it again in a different way can help and provide activation. And that is our goal, is to get women to overcome their fear or their concerns or maybe a past experience and understand what is, why different modalities may be being recommended and what the journey entails. All right, well, I feel like that went pretty quick, but thank you so much for the time, and I'm excited to be here. We're excited to be partnered with you guys. This year, we're a part of the American Cancer Society National Breast Cancer Roundtable, which has been an exciting journey. So with that, I will turn it back over to Joanne.
Thank you, Dr. Daly. That was wonderful. Folks, if there's any questions you want to drop into the chat, I'm happy to answer that. I just do want to say I think it is amazing that you have breast health specialists, and that with every test, our clinicians are going to be able to access or schedule a consult. Can you maybe just talk about how they do that once the test results come back?
Yes, so the patient will have the ability to schedule the consultation within their Auria portal. And so they'll get an email that they can, it's a Calendly link, and they'll schedule that either through their email or through their portal.
Thank you. So is that consult directly with the patient and your specialists, or the practitioner as well?
So right now we have it directly with the patient and the specialist. So okay. It's an additional layer of information for the patient.
Thank you. Dr. Sedano, anything you want to ask or any comments on here? Again, I don't have any questions that have come in, so you either did an amazing job with that, or they'll circle back around, which they usually do, and we'll certainly answer those questions. But Dr. Sedano?
Yes, Doc, thank you so much. Just a quick question. You said this is for women 30 or over. Is there a top end on this, like where you wouldn't, say 70, 80? Has that been?
Yeah, so we have, I think our oldest participant was 85.
Okay.
So yeah, we don't have a top end right now. It's normally as we age, right, there's a little more concern about anything medical. So we get questions around macular degeneration, glaucoma. It's really, that doesn't affect our test. It's really the comfort of their patient. So if they're comfortable collecting the sample, it's not won't cause any damage. It's not gonna damage our sample, but yeah, so there's not a top end, and it's really comfort level of the patient, what they're comfortable doing.
Yes, thank you so much.
Great. We do have a few questions. One of them just came in that says, can we see a sample of the findings? And I believe we do have all that here at Evexia, so we can certainly make that available to everybody, but I know we have seen the case studies and all the samples for that. So we will definitely provide that. Here's a question, Anna. If people have issues with contacts like sensitivities, will testing be difficult for them?
For most people, when they collect a tear sample, it's pretty benign. It's fairly innocuous. There's always, much like there's always people who don't like needles and don't want to get their blood drawn, there can be people who are very averse to putting things in their eye. That's pretty rare. So I would say, for myself, and I'll use myself as an example, I've collected Schirmer strip samples on myself a lot over the last 12 years. However, I don't think I could actually put contacts in my eyes. I think that's a whole different ballgame. So, I don't think if they've struggled with that it's going to negate their ability to collect a tear sample. It's actually a lot easier, and you can keep your eye closed while you do it. So, and we have some different tips and tricks on how to make it even more comfortable when they collect their sample. That come with a kit. We give them some information. So I think they should probably be okay. Again, much as it is with elderly patients, it's really a level of comfort for your patient.
Great. All right. I guess why don't we just move on and we'll go through how to order and
Okay.
that. So now that we've learned about Auria testing, I would like to review how to order the testing on the Evexia platform before concluding that webinar. Before I do that, I just want to remind everybody we do have Ask the Doctor free email consultation, any help with lab interpretation, questions, clinical conditions, and the such on the left-hand side of your Evexia portal, Ask the Doctor. As many of you have used, consulted with Dr. Sedano, he does an amazing job. So he will be learning a lot more about this lab as well, and we'll be able to answer a lot of questions. Next slide, please. So really, this is how we're going to go ahead and order that. You'll need to log into your Evexia account, and you'll go to Evexia link ordering, which is located on the left-hand column of the dashboard. Then you will select or create a patient to assign the test to. You'll find specialty labs, and then from there, go to the Namida product tab. They just have the one test in there. It's $129 is the clinician price of that. They'll go ahead and be able just to select that, add it to the shopping cart, and go ahead and check out. Orders can be paid directly by the patients or clients to Evexia, or we can bill the practitioner's credit card on file when those results come back, as we normally work with that. It's really just that simple. Under our test menu, all of our laboratory icons and our partners are there, so you can certainly click on Namida. You will find a lot of detailed information along with a sample report that you'll be able to reference and find all of that information. And really, for any questions or to learn more about Evexia, we are here 8 a.m. to 8 p.m. Eastern Standard Time, Monday through Friday. Info at Evexia Diagnostics. We are available via live chat at 8 a.m. to 8 p.m. And thank you so much, Dr. Daly, Dr. Sedano, for this informative presentation. A recording of this webinar will be available by email in the next few days. And thank you again for joining us for this webinar event. Until next time, from everyone at Evexia Diagnostics and Namida, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Thank you, everybody, and good evening. Bye-bye.
Bye.